Hello, everyone. We are ready for our CCO Student Webinar. We're already on number 32, and we got a really great topic for you. If you are doing your ICD-10 work and you are getting a little frustrated, it seems like the guidelines are complicated. Maybe you don't have a whole lot of medical background, but that's okay. The fact is that most of the guidelines in ICD-10 are based on the disease process. So I'm going to highlight some of those guidelines, and we're going to talk about it and kind of see if we can make it more applicable for you, so those guidelines will pop. The first thing is we need to discuss, why do we code? What's the purpose? If we understand why we do what we do, that helps us, again, understand the guidelines and how they would follow the disease process. Now, with the guidelines that are in CPT, in some ways that, follows the disease process a little bit because it's procedures related to the diseases, but with ICD-10 PCS, yeah, that definitely, the disease process does make a little more sense with those procedural codes, because the root operations are based on the outcome of the procedures. But that's another lecture. We'll talk about that another time. Why do we code? The very first primary reason as to why we code is for statistics. We're collecting statistics, and ultimately the statistics are going to go out to who? And I don't mean I'm asking you a question. It's the World Wide Health Organization. WHO, WHO, all caps. And they collect the statistics on mortality. But I think they do also a little bit on morbidity, but their primary purpose is mortality across the world. And then we collect statistics for mortality as well as morbidity in the United States. And because of the code sets, we're able to tell how many people in an individual area has suffered a specific disease. So you hear about things like the measles outbreak that we'll get from time to time, in vaccinations. Why do they know that? Because of the codes that are being submitted. They can track it and they can say, okay, we have had measles across the United States, but we've had an outbreak, a significant higher number of measles cases in this particular general area. And they can break it all the way down to the county. And then what most people talk about, though, is the reason that we code is for reimbursement. Now, a lot of people say, oh, but don't we get reimbursed off the CPT? We do for outpatient services, but for the inpatient services, it's based on ICD and the disease process. So in other words, if you come in to have a cholecystectomy done in a facility, the facility is going to get X amount of dollars. Why? Not because you're having a cholecystectomy, it's because you've got a diagnosis of, gallstones, and for appendicitis, that's your diagnosis. And for every person that's admitted with appendicitis, they get a lump sum of money that will take care of all of the global kind of package of what they're going to do for appendicitis. And you say to yourself, well, how do they know that appendicitis is going to cost the facility the same price to take care of 5 different people? They know because of the additional codes that we add. So if you have 5 people that come into the hospital with appendicitis, if you have a patient that is getting anesthesia for extreme age, right, then that special 99 code that you probably learned in the anesthesia. So we have somebody that's under 1-year-old and more than 70 years old. So let's say our first patient's a 1-year-old, right? the facility is going to get paid more because it's going to take more care for the anesthesiologist to take care of this patient than it would be if it was an 18-year-old patient, not of an extreme age. Same thing with our 75-year-old patient here that has appendicitis. So let's say this patient number 2 here is an 18-year-old football player, overall very, very healthy, right? They're going to not pay out as much for this fella having appendicitis as they will for these two because they're extreme age. And let's say this is a female that is pregnant with an acute appendicitis and has to have a appendectomy. Oh, that's going to pay out a lot more because if you're pregnant, the anesthesiologist, the OBGYN, all these people are going to be involved in that care, right? Extra tests will be done to monitor the baby. And then let's say that this is a fella that is coming in to have their appendix taken out, and they're 40 years old, but they have MS. Okay, well, that's gonna change, right? How you take care of that patient. Maybe the patient has MS to the point that they're not able to articulate very well, and they have to use a computer to talk, right? That's going to cost more money and time to work with that person. And then remember the 70-year-old guy here, the extreme age, we'll say 75. Let's say he's diabetic, right? And diabetics don't heal as well, and maybe he's got COPD as well. All right, so again, based on all of those conditions, those diagnoses, the reimbursement is going to change on how much each one of these fellows is going to, these people are going to, the facility is going to get paid. But on the outpatient side, it's based on the ICD tells the medical necessity for the CPT. Okay, so for reimbursement, we know that if you have 2 patients that have ingrown toenails and the provider needs to remove the toenail, okay, again, let's take the 14-year-old or the 18-year-old football player, right? Normal, healthy and everything, but he's got this really bad ingrown toenail, and the doc says, you know what, we need to go ahead and remove that toenail. I think that would be the best thing, and you'll get relief, and that new toenail will come in. And then over here, let's say we've got a same 18-year-old, right? Okay, not a difference in age, but he's a type 1 diabetic. Ah, big difference, right? So the reimbursement is going to be the same for each one of these if we didn't show medical necessity that more time was spent with this particular patient because he's a diabetic, and we needed to do more education for one, and counseling about the care and foot care, and then you had to go send him over. You said, hey, you know what, I'm going to do this, but I'm going to send you up for follow-up to the podiatrist, right? Now, when we talk about the guidelines are changing every year. The codes change every year for all the code sets a little bit. But for the most part, the guidelines don't change, but there is, verbiage is tweaked off and on. And you need to make sure that when you're coding, that your manuals, that the guidelines that you're using are for the year that you're in. So whatever year you're coding for, that's the year, the guidelines that you need to be using. Let's talk about the guidelines themselves. When you open up your guidelines, and feel free if you got your ICD manuals there in front of you, this is what you're going to see at the top of the list of the guidelines. And I pulled this directly from Find a Code, and here in a minute I'm going to actually bring over the guidelines from Find a Code, but these are some things I wanted to bring to your attention, so I put them on the slide deck. And then once we get to see how we're, how I'm telling you this and we get in a group, then I'm just going to bring over the guidelines and show you where you can print them and keep them with yourselves, but they're in your manuals. It's important that you read through the guidelines several times. We like to tell our students that you need to read through the guidelines at least a minimum of 3 times for each code set. So for ICD is what we're focusing on today because of the disease process being associated to ICD. So again, it's ICD-10-CM. Don't confuse that with PCS. ICD-10 PCS is for procedures for inpatient facility coding, and it has its own manual. So it is the official guidelines for coding and reporting. That's its name. And then right under that, it tells you that every year you're going to see changes. And in those changes, what you're going to see is things that are narrative changes are going to be bold. Okay. And then if it's underlined, it's been moved within the guidelines since, say, the previous year. And then italics are used to indicate revisions to heading changes. Why do you need to know that? Because every year there's a little bit of a nuance that's changed. And now you can just look at it at a glance and say, nothing's changed here. The font's all the same. Everything's the same. No changes. But then you'll get down to this one area and it's like, oh, wait. That's in italics. Why is that in italics? Or why is that underlined? Then you'll know, hey, heads up, something changed. And again, usually it's just the verbiage. But back in 2017, it was a significant change because causal effect changed, for example, with diabetes. And that was a huge change. And so all the wording and stuff in several places changed in the guidelines. One of those guidelines that we've been teaching for a long time. This is what it looks like when you're reading them, except for actually this is highlighted. So, and I did that on the other slides, but for this one, when we get to the area where signs and symptoms are talked about. Now, the first part of your guidelines are going to talk about where everything's in the guidelines, but signs and symptoms, that's based on the disease process. Why? Because in outpatient coding, if you don't have a definitive diagnosis, what do? You code the signs and symptoms, and that's part of the disease process. How do you know the difference between the signs and symptoms of a cold and the signs and symptoms of influenza? Because kind of the same, aren't they? Right? Don't they seem similar? Both of them can have the flu. Both of them can have upper respiratory problems and nasal congestion and stuff like that. A cold doesn't usually give you aches and pains, though. But if you're running a fever, if you're running a low-grade fever, you would have aches and pains. And the flu can give you gastric upset, but a cold doesn't usually give you a gastric upset unless you have drainage, right? From your sinuses down into your stomach, that can upset your stomach, right? So again, they're little nuances, but signs and symptoms are what are used in the disease process to come to a definitive diagnosis. And you as a coder need to know the signs and symptoms. Now, if you don't have a medical background, this is going to be a little bit of a learning curve for you. But if you've ever been sick, or you've been around anybody that's had any chronic conditions or illnesses, or maybe you have. Some of my best coding students were people that were had things wrong with them. I had one student that she'd had so many things wrong with her. She had had childhood leukemia and survived that. She had had a kidney transplant, survived that, and she had something else. I can't remember what it. Oh, she became diabetic later in life. You know, so again, she had knowledge of those disease processes that other people wouldn't have had. And so again, she was really, really good at understanding the disease process. And when we got into the guidelines, well, certain students would say, well, how come we're coding it like this? You know, who says we got to code it like this? Well, it's because of the disease process, and the guidelines tell us we have to code it this way. Why are we told to do that? Why did they determine that? Because of the disease process. And if you understand the disease process, it all makes sense. So understand the signs and symptoms, because that's going to base some of the ways that you code. Outpatient, we can code signs and symptoms until we get a definitive diagnosis. But inpatient coding, sometimes you'll be coding signs and symptoms side by side with diagnoses that are more definitive, right? It's a different type of coding. So again, we'll talk about that more. Not knowing if you're taking an inpatient credential or an outpatient credential, just know that there's differences. Moving on, these are more guidelines that are really based on disease process. It's even in the description. So this says conditions that are integral part of a disease process. Signs and symptoms, all right? And this is telling you that you do not code signs and symptoms when you have a definitive diagnosis. And that's more or less what I just told you, right? So we're okay with that. But conditions that are not an integral part of the disease process, then you're going to assign them. How are you going to look up and know if you don't know? Well, you can go out and do research on relevant websites. You can go out and Google what are the signs and symptoms to rheumatoid arthritis. And but you want to make sure you go to a reputable website. So don't go look that up on Wikipedia. But one of the best sites is Mayo Clinic and WebMD. Mayo Clinic's really good because besides them being a leader in the medical industry, one of the things that they do is they give you the education on their site as if they're teaching you. So it'll say, when you have this symptom, you will da 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 da, and so it's in that personage, like first person, second person type thing. And it's very helpful. It ends up being more in layman's terms. So as you're learning, a big part of what Mayo Clinic does is education. So for the patient, so that will help you bring up your skill level. So you can go right out to Mayo Clinic, type in rheumatoid arthritis, and it will give you a brief description of what rheumatoid arthritis is, the organs that could be involved, the signs and symptoms, the treatments that are involved, and what you can expect if this is a new diagnosis for you, right? And they'll even give you other information that you can jump out and look at. So that's a great site to see. So let's talk about, let's use rheumatoid arthritis, for example. If you have a patient that has a diagnosis of rheumatoid arthritis and they come in to see their PCP and they've got a rash and they've got a fever and they've got a sore throat, okay? Now, which one of those signs and symptoms could be associated with rheumatoid arthritis? First of all, you have to understand rheumatoid arthritis isn't like other arthritis. It's an autoimmune disorder. So if you don't know, because then you're going to have to go out and find out. Well, can people with rheumatoid arthritis break out in a rash? Yes, they can. Can people that have rheumatoid arthritis break out in a fever? They could, but that's not a normal sign and symptom for rheumatoid arthritis. Can rheumatoid arthritis patients have a sore throat due to the rheumatoid arthritis? Not really. That's not associated. So if you have a patient that comes in and the doctor diagnoses them with the aches and pains that they've got, because they say they kind of don't feel good and everything, they said, well, I know you have rheumatoid arthritis, but this rash doesn't look like a rash that most people with rheumatoid arthritis get. Because again, you can see the description of what type of a rash someone would get. It said, however, you have a sore throat and a fever. And did you know when you get strep throat, you can run a fever and you can break out in a rash? So they do a strep test and it's positive. So they did address the rheumatoid arthritis, right, to make sure that it wasn't that. And it is an autoimmune disorder. So what are you going to code for? You're going to code for the strep throat and you're going to code for the rheumatoid arthritis, but you're not going to code for the fever and the rash because they're signs and symptoms of strep throat. Okay, see? Now, if the patient had no signs and symptoms, or let's say the patient had the rash, but didn't have, and had a fever, but didn't have the sore throat, and the doctor says, yeah, I think this is a rheumatoid arthritis flare, then you would code the rheumatoid arthritis and nothing else, because he would say that the rash and the fever, everything's due to that, even though fever is not generally one of those things that's associated with rheumatoid arthritis, although it could be if he states that it is, right? So it follows the disease process. What about when we have to code more than one code to give a full description? This falls under etiologies and manifestations. Now, if you need more education on etiology and manifestation, we did that in a, it'll be in the club, or you might be able to go find it on the YouTube channel where we just did a student or a club webinar or something on etiology and manifestation. So ultimately, etiology is where did it come from? Manifestation is a result of the condition. And when we code those, then we code them in a sequence. The guidelines tell us that when we're using more than one code to give a description of something, that we're required to use more than one code, there's a sequencing that we have to follow. So how do we code, and if we're told we have to code the etiology and the manifestation, how do we know which one to code first? Well, the disease process is going to really help you, and because you're going to know the etiology and the manifestation. But there's always exceptions to the rules. But you don't have to have this memorized. When you go look at the codes themselves, so you go up and look at the etiology and the manifestation. Let's say that the etiology and the manifestation is something very basic like diabetes with renal complications. Okay, what's the etiology? The patient has diabetes, and as a result, they're having a manifestation which is affecting the kidneys, and so they have CKD. Okay, so what's the etiology? Diabetes. What's the manifestation? CKD. Well, when we can even get it more fine-tuned, and that there is a diabetes code just for patients that have diabetes and renal manifestations. So we would code that, and then the manifestation is this CKD. So we would code the N18 point whatever the stages, like stage 4 CKD, right? So it would, or stage 3, so it'd be N18.3. And then it's not going to be E11.9 for diabetes. No, it's going to, if they're type 2 diabetic, it's going to be E11 point, and I can't remember if it's a 3, 4, or 5. That's renal manifestation. I kind of want to say it's a 4, but I can't remember off the top of my head. So we're directed to code the diabetes first and the manifestation second, unless the others being treated and stuff like that. But when you go to look at the code for diabetes with renal manifestation, it will tell you next to that code, use an additional code to identify what stage of CKD the patient has, thus N18.3, right? They have stage 3, okay? Now, you will also see sometimes if you have a patient that has CKD types 3, okay, stage 3, and you go look at that code and it says if the patient is a diabetic, right, then code first the diabetes, and then it tells you code first means I code this code first, and then when you see use additional, then you code the rest. Why do we do it that way? Because of the disease process. Would the patient have had CKD if they weren't diabetic? No, because the CKD is renal manifestations very common with patients that have diabetes, as well as other manifestations. You have problems with the eyes, you have problems with the skin, you have problems with the PNS, the peripheral nervous system, etc. I could just keep going on and on. It affects every body system ultimately. So the disease process tells you the patient's diabetic. That's what we're coding first. What's the manifestation? What's the result of them being diabetic? CKD. This happens with hypertension and CKD because chronic hypertension tends to make people have chronic or have issues with their kidneys. People who have CKD tend to almost always have problems with hypertension. So they're linked, and it's going to tell us use in additional a code, and then it's going to say also when you get to that other code, code first, right? It follows the disease process. That's how we know. Okay, let's move on. And code first, again, you don't have to do any guesswork at this. It's going to tell you to code first. But keep in mind that sometimes you'll have things that aren't applicable, right? So just because it says code use in addition or code first, if that's not applicable, then we're not coding it. So let's think of a correlation for that. You have a patient that is diabetic and they have CKD, and the doctor has specifically stated that this is not linked. So they have to specifically tell you, you have a type 2 diabetic and they have CKD type 3, okay? But the CKD is not due to the type 2 diabetes. All right, that's different. That means those are two standalone conditions. It's not an etiology and a manifestation anymore. So if the patient is being seen for that encounter for their diabetes as well as the CKD, which one are you going to sequence first? Right? Well, it doesn't really matter because they both are standalone diagnoses because the doctor split them up and said, no, they're not causal effect. They are completely different. You know, they may even say the patient had CKD before they got type 2 diabetes. Okay. All right. So they didn't get type 2 or they didn't get the CKD because of the diabetes, which is very common. No, this is a different case. This is two separate things. And we're adjusting their medication for that now they're going to move to insulin. So we're addressing that with the diabetes. And then we're also going to send them to a nutritionist because of their CKD. We don't want them, they need to cut out salt, and we need to talk about how much fluids they intake. They need to learn to regulate that, and it'll also help them with their diabetes. So which one is, both of them, they stand equally. It doesn't matter which one you code first, right? And so it has to be applicable. What are some diseases that have specific guidelines based on a disease process? Now, I came up with two that are very common besides diabetes: cancer. The guidelines for cancer are very blatant, you know, especially when sequencing. But the guidelines for primary malignant cancer, secondary malignant cancer, and the sequencing that's dealt with that. And then also we have cancer in situ. And then you start having those behavioral, we don't know what, you know, kind of what it's going to do type codes. Now, when you look at the table for neoplasms, the primary malignant and secondary malignant is listed first. And then it does the cancer in situ, right? And benign cancer. I forgot benign cancer. So think about the disease process. Which is going to be more severe if a person has malignant primary cancer or benign cancer as far as the disease process goes? Well, malignant. is a more severe type of cancer because it means it can move someplace. Benign isn't going to move someplace. Now, can benign cancer cause problems? Absolutely it can. But the disease process is not as difficult or complicated or complex in benign cancer as it is malignant cancer. So if a person has two types of cancer, one is primary malignant and one is benign, right? Which one's going to be listed first if we are dealing with both of them, addressing both of them at that encounter? Well, you're going to list the primary malignant cancer first, right? Well, and because it is the whole disease process is more complicated. The medical decision making will be more complicated with the primary cancer than it would be with a benign cancer. Okay, and sequencing guidelines for when we're treating both a primary and a secondary cancer. So a patient has brain cancer, primary brain cancer, and secondary lung cancer. And both are being addressed in that encounter, in that visit. Which one will be sequenced first? The primary, and then the secondary is listed second, okay? Because where did the cancer start? In the brain, and it moved to the lung. So the disease process tells us that's the guideline. We're going to go with primary and then secondary. However, with the disease process, if the patient's being seen for a pulmonology visit and they're addressing the secondary lung cancer, not the primary brain cancer, but it's applicable, right? Because they have two types of cancer, which is going to be coded first. The guidelines tell us that we code the secondary cancer because that's what's being addressed. The medical decision making is based primarily on the lung cancer because it's a pulmonologist, right? A specialist for the lung, right? And so the disease process tells us how to code that. Right? Anemia. Now, when you look at your manual and the index for anemia for ICD-10, there will be multiple pages for anemia. There's lots and lots of really unique things happening in with anemia that signifies one type or another type. And the guidelines are complex, really, when it deals with anemia. When you first start looking at it, you think, oh, okay, so I'm supposed to code it this way, the anemia first, but no, wait, no, I'm supposed to code the condition first. And then, nope, but there's an exception to the rule. So this time I got to do this first. It doesn't make any sense. But the guidelines really, truly follow the disease process. And it has to do with what is the reason for the anemia? Do we have anemia due to the cancer? Okay, so think to yourself, what organ would cause anemia? What type of anemia could be associated with a cancer? Well, you could have a bone cancer might cause anemia because the bones produce blood components, the spleen. You could have also just a blood cancer, some type of leukemia that or a plastic myeloplastic disease or something. But it again, the blood components are being affected, so it might result in anemia. So is the anemia due to the cancer? Well, there's guidelines that tells us which how we code, the sequence that we code, if the anemia is caused by the cancer, and it's based on the disease process because the anemia is due to the cancer. Now, when a person has cancer and is undergoing treatment, there are times that the immunotherapy or the chemotherapy that the patient is getting will cause anemia. So then you have to ask yourself, and it's in the documentation, the patient has anemia. Is the patient's anemia due to the cancer or the chemotherapy? Well, if it's due to the chemotherapy that the patient's getting, not to the cancer, So they wouldn't have gotten the anemia if they weren't getting the treatment for their cancer, in other words, and it's spelled out in the documentation. The sequencing for the codes are different than if it was the cancer itself causing the anemia. Why? Because of the disease process. And that's all listed in the documentation. So when you think of it this way, then the anemia, which is kind of, all these different rules and guidelines that say, oh, you do it this way, except if, right? That'll make sense because you step back and you say, what's the disease process telling me? Right. So next, we're going to look at the specific, a little more in depth, and actually look at the guidelines. Now, you can turn in your manuals to look at the guidelines with me, and I'm going to pull over Find a Code. If you don't have an encoder like Find a Code to be able to get the guidelines off of, Find a Code even tells you where you can download the guidelines, and that's off cms.gov. But let me just see if I can get down here at the end of the page here to show you real quick. Right here. So where's the source? You can get this off of the cdc.gov/NCHS/ICD/ICD-10cm.htm. But if you have Find a Code, you can just download it from there. Okay. You can go to cms.gov and just type in the year and ICD-10cm guidelines, and it'll give it to you. And then I would download that, and then you can print off the form, the PDF, and when you print that off, you can make notes all over it, right? Before you put them in your manual. Plus, it's a lot easier to carry around those like 107, how many pages we got in there? Let me look. 117 pages of guidelines versus 120. So last time I printed it off, it was 117. But still, if you want to, you could print those off. It'd be easier to carry around those and study than carrying that big ICD-10 manual. So this is exactly where I got the beginning that we talked about. And when you're looking at your guidelines, let's follow down here. Let me scan down just a little bit. Follow along with me. Now, we're not talking about the guidelines specifically, okay? Because we already did training on that. Go out and look at the CCO Club. And it was, I remember doing a webinar on how to read the guidelines. It was probably in CPT or ICD, but I suspect it might have been in both code sets. So it starts out just educating you on how to read, what to look for in the guidelines. And then it talked about here this etiology and manifestation, right? So then over in on page 14 was those conditions that are integral part of the disease process. How do we code that? And it told you to do the code also and in addition codes. That tells you that when it says code also, then that means that you're going to, code that first. In addition, it's sequenced second. So let's look at more conditions. Now we looked at multiple and single codes where we talked about that in etiology and manifestation. But what about acute and chronic? Let's talk about those because that's truly based on the disease process. And so that's over on 15. So let's see if I can get to 15 real quick by coming up here. If you guys didn't know how to do this, you scroll up here to the top and then just type in 15 and then scroll down. And this should be, you can see it, we'll scroll down to the end of the page. It's really nice. See, page 15 of 120, it tells me. So now I'm going to scroll up and kind of get this all in here. I want to know about acute and chronic conditions. So the guideline tells you very blatantly, if the same condition is described as both acute and chronic, and separate subentries exist in the alphabetic index, so you have a code for acute and you have a code for a chronic, but you don't have an acute on chronic, then you are going to code both, and you code acute first. Why? Because we think about the disease process. If a person has a, I usually always go, when I talk about acute and chronic, to asthma. But let's say that we have a person that has an acute asthma attack, okay? And they also have another condition of the lungs. And let's, if we give them COPD. Now, just real quick, pause and remember that there may be an acute and chronic code for asthma and COPD because they fall under the umbrella of COPD. Asthma does. So I'm using this for example, so take it with a grain of salt. If you have a person that, let's say there's two separate codes, there's not a combo code that says acute and chronic, but we have acute asthma attack and the patient has COPD, which is a chronic breathing condition. Okay, what gets coded first? Well, the acute, because what is the problem they have to treat immediately? The disease process. The acute, always acute has to means sudden onset, right? If a person has respiratory problems, then of course, which is going to get coded first. If a patient has COPD and they have acute respiratory failure, which is going to get coded first? Acute respiratory failure. It's acute, it's sudden, it's something that has to be treated immediately, especially if it's respiratory failure, right? The patient is going to die because the respiratory system has failed to work. It's an acute problem. That gets coded first. It's more severe than something that's chronic and ongoing, right? So don't get confused that, oh yes, but this is a chronic condition that's really, really bad. But the disease process tells us that if something is sudden onset and an acute, it needs attention immediately. And so that's going to be the primary focus of the encounter, no matter where it is. Acute always will trump chronic and be listed first unless there is a code for both of them. And I think there is one for acute exacerbation of asthma and COPD. Okay, then that would be a code that you could code together, one code, and it doesn't matter because it's one code, a combo code that handles both. But if you have a code for an acute condition and a chronic condition, the acute always gets listed first. They'll test you on that, but it's based on the disease process. And that kind of leads into combination codes, right? How they work. Now, let's talk about sequelas. That's a late effect. Sequelas are not listed first, but notice right here, there's an exception to the above guidelines, and that is if the sequela is followed by a manifestation code identified, okay, and the code to the acute phase of the illness or injury that led to the sequela is never used with the code of the late effect. So can a sequela be listed first? If the patient's being treated for the sequela, yes, but it's a sequela code, meaning it ends in an S usually, okay? Because of the disease process. It's a late effect of something that happened. Now, when I talk about sequelas and teach on sequelas, I usually talk about burns, because if a person has had a third-degree burn of a hand, there's usually enough scar tissue that the patient isn't able to articulate their joints very good on that hand, and they may even have lost part of their fingers, and so they may have to go in and have procedures done to loosen up that scar tissue just so they can manipulate their hand and use it properly, right? So that's important to understand that. Why are they being treated? Well, for the burns, or they're being treated to be able to move and articulate the joints, but why can't they? Because of burns and the scar tissue. So the late effect is the not ability to articulate the joints, right? So why are they being seen? The sequela, not the burns. The disease process really plays a part on impending and threatened conditions. So this is another one where it gets confused for new students, especially. They said, wait a minute, I thought we couldn't code something unless it was, you know, at the highest specificity. So if we have a impending MI, an impending heart attack, we can't code that because they're not having a heart attack, right? We do the signs and symptoms. But the fact is there is actually a code for that. So that is the code description, because they can look at an EKG and say, oh, wow, we got a problem. This guy's going to has an impending heart attack. You know, it hasn't actually, the blockage hasn't happened yet, but it's going to happen. And so there's guidelines that follow when you can use the term impending or threatened, and specifically with discharge. So it follows the disease process. Can we have an impending MI? Yes. Or a threatened MI? Yes, we can, because it is a diagnosis in and of itself. Now, that doesn't apply to everything. Can we have an threatened pneumonia? Well, they could code that. I mean, they could say that in the documentation, but that is not a definitive diagnosis because that isn't part of a disease process. Okay, you either have pneumonia or you don't. Okay, I mean, you can't have a threatened amputation. Now, can they state or use that, you know, verbiage and say impending amputation if we can't get this diabetic ulcer healed? Yeah, well, don't confuse that with a diagnosis. That's a description that they're talking about. The disease process is, if we have an amputation, we have an amputation. You don't have a pending amputation or a threatened amputation. That's not a diagnosis. Okay, we have to understand the disease process and the verbiage that is affiliated there. Okay, let's see. Laterality doesn't really follow the disease process. Syndromes, though, syndromes follow the disease process. Whenever you have a patient that is diagnosed with a syndrome, then that may or may not be classified under syndrome when you look it up, but a lot of times there'll be codes for manifestations that are not an integral part of the actual disease process. So right here, an additional code might need to be used, that they're not an integral part of the disease process, but may also be assigned when the condition does not have a unique code. Okay, so that's all part of the disease process. We have to understand it. Let's see, borderline diagnoses. There is a diagnosis for borderline conditions. So you need to go to the index and you need to look borderline and then see what they are, because it is a diagnosis. It's not, it's part of a disease process, borderline. And that's why we have that. Let's see, we're going to skip through there. I think that's about it. Okay, we do need to cover HIV, though. It follows the disease process. Why do they tell us there's two codes? You can be HIV positive and you can have AIDS. They're not the same disease. Okay, what happens is the HIV virus, meaning you're HIV positive, you've been tested and you tested that you have this virus in your system, it can turn into AIDS, which is a different disease or a different condition. It is escalated into AIDS, right? It would be the equivalent of saying, and of course I'm really reaching for extremes here, guys, but a person who has a really bad sore throat, you know, what is the difference between having a very bad sore throat that maybe is tonsillitis, an inflammation of the tonsils, and having strep throat? Well, the difference is that you have the strep virus, right? You have streptococcal, you test positive for that, okay? And it's manifested itself. Now, we actually have strep and staph and all that stuff in our system anyway, but it doesn't manifest it. It doesn't manifest itself unless we get sick, right? So think of that with AIDS. A person can have the AIDS or the HIV virus in their system, so they're HIV positive, but that doesn't mean they have AIDS. AIDS means that they have manifestations of that HIV. It has progressed. It has the immune system has been suppressed to where you have a condition that takes advantage of that suppressed immune system and turns it into now symptomatic HIV, which is AIDS. And the guidelines follow the disease process. So if a person is HIV positive, they're Z21, right? But if they have AIDS and it manifests itself, it's B20. But you never code those together because they either have AIDS or they don't, right? Now, a person that has AIDS is HIV positive, right? That's just a given, but a person that has HIV, is HIV positive, doesn't have AIDS unless they become symptomatic, right? So the disease process tells us you never code those codes together, right? And again, when you understand the disease process of HIV, being HIV positive, and AIDS, as well as the conditions that make HIV symptomatic, and there's like 13, 15, or maybe even there's up to 30 now, which are diseases that are symptomatic. Once you know that, then you understand how the process works and why the guidelines are set up the way they are. Okay, so let's look at some, let me go ahead and move this out. I'm going to just get rid of this and let's go to our next. We're going to now answer some of the questions that came up. So Whitney says, is there a difference between transient level of awareness and altered mental status? Yes, there actually, I believe there is mental status, altered mental status. There is the, you can use the Glasgow score to get altered mental status leveling and a coma scale, so, and it has to do with, is it a person able to verbally respond when you talk to them, when you touch them, when shake them, or are they able to respond not verbally, but when you shake them or you do something to cause them pain, like rake your knuckles across their sternum, and they go, oh, like that. That is a type of stimuli response that you're getting, and so it's scored on this Glasgow coma scale, and that can show altered mental status. Now, transient level, though, is a little bit different because the word transient means that it's changing. So, and it usually doesn't last very long. So I think that transient level is different than altered mental status. Yeah. Someone might say that's different, but I don't see them as the same thing. But that would be a really good thing to do some study on. Yeah, to show the difference and how the documentation shows difference. But whenever you have altered mental status, you're probably going to have some type of scoring system that's involved in that. Whitney says, what if it doesn't say if the condition is acute or chronic? From the example, pulmonary edema, you would just assume acute. Well, there's a guideline that tells us that. What do we do? So when you're not given the information for acute and chronic, right, then there's a default. That's like saying if we are not told what type of diabetes that the patient has, type 1 or type 2 or some other type of diabetes, then what do we default to? It says we default to type 2 because 95 to 98% of diabetics are type 2 because of the disease process and our understanding of the disease process. That default was put into place. Okay. If a person has pulmonary edema, and if you don't know whether it's acute or chronic, you can query the provider, of course, but acute is what you're going to go with. Yeah, it's considered acute unless you're told that you're chronic. Why else would they be there? Right? They got pulmonary edema. But again, if you're ever in doubt, you go back and check the guidelines, right? And where are you going to find that? You're going to look up pulmonary edema, okay, in the index. Then you're going to go to the tabular, never code from the index. You're going to go to the tabular, and you're going to see what guideline is there and tells you what to do. If it doesn't indicate whether it's acute or chronic, it's going to tell you this is how you code it. Now, if it doesn't, then you're going to go look at, and the guidelines don't give you the answer, you're going to go look up coding clinics and find out, right? These are just reference sources, because honestly, I can't remember the guideline off the top of my head, so I can't tell you for sure what you do. All right. Well, that is going to wrap us up, guys. Again, if you want a better understanding of the guidelines themselves and why we code the way we do, why the guidelines say something specific that just doesn't seem right to you, go back and research the disease process, because that's usually why it's done. And it'll make you a better coder. It'll make you test faster, and it'll make you faster in the real world too. So understanding the disease process is huge when you're dealing with coding and understanding the guidelines. And if you're going to sit for a certification exam, really, what are you being tested on? The guidelines, understanding of the guidelines. That's the disease process. All right. Thanks, guys. If you have any questions, go out to the CCO Club and post them there. All right. Bye.